Hello friends, I am Dr. Raghav Bansal. I am Associate Professor of Cardiology at UNMICRC Institute of Cardiology and Research Center. Today we are going to talk about how to implant a coronary sinus lead during a CRT implant. This is a primer for the fellows who are beginning their careers and starting to implant a lot of CIED devices and are intimidated by CS lead implantation while doing a CRT. So just to introduce, I just wanted to tell you that what we desire out of the CS lead implantation, where the CS lead should be implanted. So CS lead implantation to appropriate LV location is very important for a good CRT effect, but it is rate limiting, and there may be a 5 to 10% of failure in CS lead implantation to an adequate location, which is a rate limiting step for CRT implantations. However, newer hardwares are available which always allow us to implant in difficult situations and grossly improved our success rates. It allows for the easier access, better visualization and maneuverability of the pacemaker lead. And mid-lateral left ventricular wall lead placement is the preferred side. It may be a posterolateral vein, lateral marginal vein, or the lateral branches of the anterior interventricular vein. So this is a diagram of the coronary venous anatomy, where what we can see is that there is a CS ostium and the posterior most branch is the middle cardiac vein, which is along the septum. Then we have a posterior, posterolateral and the lateral branches, which might be appropriate for a lead implantation. And then there is the anterior interventricular vein, which is along the septum again and is not a good site. So anything which is near to the septum, the anterior interventricular vein or the middle interventricular vein are not good sites, and anything near the lateral wall like the lateral and the posterolateral veins are good sites. So this is another diagram. So we always see the coronary venous anatomy in two views, the RAO30 and the LAO30, and we'll try to highlight the importance of these views. And the basic thing is that whenever we see these views, we should know that we have to go in the lateral vein branches in the LAO view, and in the RAO we should try to remain basal. So this is a practical diagram from the fluoroscopic anatomy. So in the RAO view, we can decide that if the lead placement is in the basal part or the mid part or the apical part of the left ventricle. The best part where we can put a lead is the basal part. So the basal LV lateral wall pacing is the best for CRT response. And when we see on the LAO view, it is easier to define that are we on the septum or on the lateral wall. So what is a good LV position, lead position in the X-ray? So when we say see a lateral X-ray, so AP view X-ray may not suffice for checking the that if the LV lead position is good or not. We need a lateral view X-ray, and the distance between the tip of the LV lead and the tip of the RV lead is a good marker for acute hemodynamic response of the CRT. So this is again a slide which shows lateral X-rays of a non-responder versus a responder. So on the left side of the figure, we see a figure where LV is probably implanted, LV lead is implanted in the anterior interventricular vein along the septum, and what we see is the tip of the LV lead is near to the tip of the RV lead, the distance is small. But when we see there was another lead implanted later because there was lack of CRT response, and now the patient responded and the distance between the LV and the RV was much more than before. This is again another example where reimplantation of LV lead was done due to non-response, since LV was very near to the RV. So what practically we are trying to attain is that the last part of the LV, which is getting last activated due because of the broad LVBB QRS, we are trying to activate it first. So we have to go to the basal lateral LV to get a good CRT response. So this is one prime thing which we need to know so that we can go ahead with the procedure. Now, starting with the procedure, getting started, we all know about implanting the dual chamber pacemaker. I at least hope so. So I'm not going into those details, and you know about how to set up the trolley and everything. So I'm not going into those details. So we just use the preferred method to access the axillary vein. Many people do a cephalic vein puncture, which is also acceptable. We often use only axillary vein access, which is the best possible access according to me. We can also do an extrathoracic subclavian puncture if axillary vein is difficult to find. Then we have to use a specialized lead introducer for the CS lead, which are long sheaths, and they are 9 French or 10 French sheaths. They are usually larger. They can also accommodate sub-selectors, vein selectors. So that's why they are made larger. There are two types of sheaths, peelable and slit away sheaths. Slit away sheaths are more commonly used. Peelable sheaths are only available with Abbott right now. So we have to prepare all the delivery system components before the procedure begins. We have to flush all the lumens with heparinized salines. So since these are large sheets and the LV lead is only 6 French or 5 French, so there is a gap between the lead and the sheath, and there is a high probability of getting a clot inside the sheath. That's why we need to flush all the lumens with heparinized saline from time to time. We have to often use a venogram balloon catheter to delineate coronary sinus anatomy, and we should flush and test the balloon beforehand before going inside. And all the guide wires which we are going to put inside, we should try to first wet the wires with the heparinized saline so that there is no clot sticking here and there. We should think about backup pacing when we are doing a CRT, because even if these patients are not in AV blocks, so these patients have left bundle branch block, and we are going on to the right side of the heart, and if we hit the right bundle branch and we cause a catheter related bundle branch block, we might cause a complete heart block, because LBBB plus RBBB may lead to a CHB. So we need to be cautious of that, and we have to have a backup pacing ready when we are trying to implant a CS lead, because sometimes CS access may be difficult and we might hit the right bundle. So there are two options. We can go with an RV lead first. So we can just put an RV lead, which is pretty much easy to put and does not require much of manipulation. We can put a RV lead. It can provide a landmark for the coronary sinus and can be used to provide a backup pacing while we are doing the CS lead implantation. And it also helps to visualize a tricuspid valve. But once the RV lead is in, so there are two worries: that it may interfere with the CS ostium cannulation, and the second, that the RV lead may itself get dislodged while implanting a CS lead. So some people may also go with the LV lead first, which it makes easier for us to cannulate the CS, but we need an additional method to provide a backup pacing, which may be in the form of a TPI implanted at the RV apex. And the worry is that it may get dislodged while implanting the RV lead. So to prevent that, we usually keep the sheath inside, the CS sheath inside the CS before implanting the RV lead, and only after the fixing of the RV lead we take the CS sheath out. So in my practice, I usually do an LV lead first, especially in those patients who don't require pacing, because if the LV lead implantation is failure, I can completely abandon the procedure without opening the RV lead. So step by step implant procedure. First we have to cannulate the coronary sinus, then we have to perform a venogram, then we have to select appropriate veins and the leads, and then we have to place the lead, measure the electrical parameters, and we have to then remove the implant tools. So we'll go step by step. First, the coronary sinus cannulation. So for the coronary sinus cannulation, we need to understand the coronary sinus os anatomy. So if we look at the right atrial anatomy, so this is kind of an AP2 slight shallow RAO view. So what happens is, if we have opened the anterior wall of the right atrium, so we see the coronary sinus os in the inferior part of the right atrium, just behind the tricuspid valve, just posterior to the tricuspid valve. It is along the septum, and it is lying in the triangle of Koch, just anterior to the eustachian ridge. So this is the anatomy of the coronary sinus. So it is just posterior to the tricuspid annulus, along the septum, in the inferior part. These three things you need to remember. This makes our job easy. So what we are trying to use is a dedicated CS sheets. So we have a lot of dedicated CS sheets from all the major companies who are providing us with CRT implants. So these sit beautifully inside the CS, and once they go into the CS, they give a lot of support. So coming to there are multiple curves available from the companies. So these are the curves, multiple curves available from the Abbott company for the CS sheets. So we have a right side special curve, then we have a 115 degree curve, 135 degree curve, and a wide and extra wide curves. So the standard curve, which is used for a CS lead implantation in hearts where the RA and RV is not much dilated, it's a 115 curve. If the RA and RV dilatation is much more, we can use larger curves, the 135 degrees or a wide curve, to get an access to the CS sheath. And in specialized anatomies where there is a kink in the CS ostium, or there is some significant problems, we can use AIM cannulators like the AL2 curve and all. So regarding locating and cannulating the CS, this is a simple step-by-step procedure of how to cannulate the CS. This is started in the RAO view while we try to cross the right ventricle into the right ventricle through the tricuspid valve. This can be done by passing a guide wire into the right ventricle, and over the wire we can push the sheet inside the right ventricle. This can be confirmed with the presence of right ventricular PVCs on the ECG. Once we are in the right ventricle, we have to give an anti-clockwise torque so that the catheter faces the right ventricular septum. And before this step, we have to remove the guide wire, and once the sheath is facing the right ventricular septum, since now it is in the plane, now remember the CS ostium is in the plane of the septum. So now we start pulling it back. So once it is out of the tricuspid valve into the posterior right atrium, as soon as it enters from the right ventricle to the right atrium, it is the location of the CS where it can cannulate. It will just fall into the tip, will just fall into the CS ostium, and there we can pass the guide wire again into the CS, and then over the wire we can just push the CS sheet into the coronary sinus. Another is a telescoping method. If it is not easy to get into the CS by this method, we can use a lot of catheters and curves which are suitable from a case to case basis. This you have to select on a case to case basis while looking at the CS venogram, that how the CS os is aligned to the right atrium, and according to that we can choose a lot of curves. It can be a JR curve, the AL2 curve, or a multi-purpose curve. The most commonly curves which are helpful for this purpose are the JR5 or a multi-purpose curve. AL2 curve can also be used especially for dilated hearts where the angulation of CS is with the right atrium wall is more acute. So in these cases we can just put a catheter inside the sheath and we can cannulate the CS with these catheters, pass a guide wire, then push the catheter over the wire into the CS, and then over the catheter support we can push the CS sheath inside. This is called as a telescoping method. Or if you have the luxury of having a deflectable EP catheter in your cath lab, you can always go for that, because it is much more easier to go with a deflectable EP catheter and cannulate the CS and then push the CS sheath over the deflectable EP catheter inside the CS. So troubleshooting CS cannulation. So what are the common obstacles, common problems which we face while CS cannulation? So one is that variable CS ostium location. So in some cases the CS ostium location may be very odd. The direction of the CS originating from the CS ostium may be at an acute angle. This is especially true for very dilated right atriums and dilated hearts. Sometimes there is a prominent Thebesian valve at the opening at the CS ostium, where it will make life difficult for passing the CS sheet into the CS. You might be able to pass the guide wire easily, but the CS sheet may just simply refuse to go. And change in takeoff angle due to LV enlargement, which I have already said. So these are the valves obstructing catheter or LV lead advancement. So what we see is there is a Thebesian valve, which is a membranous valve covering the posterior and inferior aspect of the CS ostium. It is a extension, essentially an extension of the Eustachian valve, and it may be present in 10 to 20% of the cases, and it can impede CS cannulation. If it is happening, we can put for a firm support so that CS sheath can be pushed, we can use a telescoping method with a catheter or a diagnostic catheter or an EP catheter. So this is an example what happens when this is the AP view. So when the heart starts enlarging, it keeps on enlarging. The angulation of the CS from the right atrium keeps on changing because the left ventricle enlarges and keeps on pushing the CS ostium. So once this is very enlarged, so the angulation is not in the plane in which the curve of the CS sheath lies when we enter from the superior vena cava, and this may make life difficult while cannulating the CS. Troubleshooting CS cannulation. It is very important to take a late phase coronary angiography. If you are especially in your starting phase of the career, it is very important to take a late phase coronary angiogram. This is done by taking a left main chute and doing a long injection and taking a long cine, so that you have a follow through in LAO and RAO views, so you can delineate the coronary sinus anatomy. This is very important for everybody. I recommend this for everybody. It should to be done before doing an CRT implant, so that when you are going into the procedure, you know which vein to choose, are there any veins or not, and how is the CS anatomy, so you are better prepared in your mind which curve to choose or not. And you can also just prognosticate the patient regarding the success of the patient once you have a look at this coronary sinus anatomy. You should have a contrast flushing, you can use a contrast flushing test in the low RA in the LAO view. So once you are in the LAO view and you are in the low right atrium and you are not able to cannulate the CS, you can just inject some contrast there and see if you can see the CS ostium. If you are able to see the CS ostium, it will help you give the direction where you want to go. If nothing is helping, you have to switch to a different curve. Don't delay it too much. If you have made attempts for 5 to 10 minutes and it's not happening, you are not able to go into the CS, try a different CS sheath curve. If the RA is dilated, go for a larger curve, or if it is angulated, go for a AL2 Leica curve. You can also use a coronary angiographic catheter like an Emplart's catheter or a deflectable EP catheter, which is very, very helpful. It is good to have a backup of an EP catheter if possible. And crossing with guide wire, if the CS, you are able to cross into the guide with a guide wire into the CS but not able to pass the sheath, you can always use a balloon support. You can inflate a small balloon inside the CS, and with that support you can push the sheath on the inside the CS, or you can also do a small balloon angioplasty there if there is a stenosis there. Performing a CS venogram after cannulating the CS is the next step. This is important to provide a clear visualization of the cardiac venous anatomy. It is difficult sometimes to be very sure about the CS tributaries in an angiogram which is done as a follow-through coronary angiogram. So this increases the chances of successful lead placement, as you have a very nice view of the coronary venous system, and it also gives us regarding the insight into the size and the tortuosity of the tributaries, so we can select the appropriate vein. So the best way to perform a venogram is with a balloon catheter. The balloon should be inflated and deflated several times outside so that it doesn't get stuck inside. And when we are taking a shot, just give a small proof shot first, so to see that the lumen of the catheter is freely lying inside the CS and it is not adjusting the wall of the CS to prevent any dissections of the CS while injections. And then once you are sure that it's in an appropriate position and it's blocking the CS ostium properly and there is no backflow so that the venous anatomy is properly delineated, then we do a prolonged contrast injection with 10 to 20 cc of dye for retrograde filling of the vessels. This should be done in two views at least, the RO and the LO view. The importance of the multiple views cannot be overemphasized. Like we all know, we have seen in coronary artery anatomy also. So sometimes, like in this example, if you see the LO view only, you see that there is a good target lateral branch in which you would like to implant the CS lead. But if you see the RO view, this branch arises much more near to the proximal CS, much more near to the CS os as compared to seen in the LO view. So if you have seen only the LO view and you are trying to cannulate this lateral branch, you are trying to go distal to that ostium of that branch and then trying to cannulate this branch, it will be impossible to cannulate this branch until and unless you switch to the RO view and then try to cannulate. So that is very important. To know the importance of multiple views. So this is another example. You see a double density in LO view, but still it seems everything is fine and you should be able to cannulate and do everything properly. It's a very nice big vein where you can implant a lead. However, when you see the RO view, there is a significant stenosis in that CS segment which is not clearly seen in the LO view because of the foreshortening, and this stenosis needs to be tackled before the delivery system can be pushed into the appropriate target vein. So what are the complications of doing all this? Putting a balloon catheter, taking a shot and trying to push all the delivery catheters inside the CS. You can cause venous trauma. You can cause a venous dissection which may lead to a tamponade also. So you need to be wary of that risk. If you are suspecting anything wrong there, you should always check an echocardiogram to rule out a tamponade. And if you are injecting too much dye, it adds the risk to the patients with renal insufficiency, and many of these heart failure patients already have kidney injuries. Going to the next step, how to select the target vein and the LV lead. So you have to look at the target left ventricular free wall. So we want to go to the lateral basal free wall. So veins in the 2 to 5 o'clock positions in the LO view are the best veins. The lateral cardiac vein, the posterolateral cardiac vein and the posterior cardiac vein is also okay. These are the best veins. If you don't have any vein available in the A, B or C location, then what we can do is we can choose, if we can see closely to the posterior middle cardiac vein and the anterior intercardiac vein, and we should see if they have any branches going towards the lateral wall. This is all obviously true because the left ventricular lateral wall has to have some venous drainage. So if there are no direct branches to the CS from that area, so they are more likely to have branches towards the middle cardiac vein or the anterior interventricular vein. So you have to specifically look for those lateral branches in the septal veins. If you get those good lateral branches, you can implant from there into the lateral branches also. So again, this is an example how to choose a vein. So this is the middle cardiac vein in the LO view, but you want to go to the lateral wall. You cannot just implant a lead there. And in the RO view, you decide how distally you go towards the apex. The apical position is not the best one. You should try to get the pacing into the basal or the mid region to get best outcomes. So select vessels that maximize separations between the RV and the LV leads. This can be seen in the steep LAO views if your lab allows, and avoid infarcted myocardium and phrenic nerve stimulation. So you should always have a look at the echocardiogram before doing the procedure and see where the LV scar is. If you know where the significant scarring of left ventricle is, You should try to avoid those areas. Sometimes these scarring may be seen as a calcified region on the fluoroscopy also. And you should be always thinking about the phrenic nerve stimulation, which is always maximum at the lateral part of the LV, where the desirable LV lead location is. So always test for phrenic nerve stimulation. If it is there, try to position your lead somewhere else. And also look at the diameter of the vessels. So very large vessels, you would be happy that it's a very big, large vessel and you would be able to implant the CS lead. But easier the implantation of the CS lead on that vessel, easier would be the lead to get dislodged and come back, because these are not active fixation leads, these are passive fixation leads. They are just lying inside the CS tributaries. So sometimes it's good to have small branches where you can wedge the lead tip into the branch so that the lead does not move much and does not get dislocated. So this is an example where AP view shows the RV lead placement in the interventricular septum. However, when we go to the LAO 40 view, we should have a good separation with the LV lead and the RV lead. A good rule of thumb is when we are seeing in the LAO view, so there is a septum which is seen in the middle of the heart in the LAO view. So on that septum is the RV lead, and then there is a posterior border of the heart. If your LV lead is near the posterior border of the heart, then you have done a good job. Then you are probably at the lateral LV wall and you will get a good separation from the RV lead. Going next, we have to now place the LV lead. Now we have the vein where we want to enter, and now we have to place the LV lead. So LV lead may be sometimes complicated by tortuosities or angulations near the origin of these CS vein branches. So if there is an angulation or there is a lot of tortuosity, then we can use subselection catheters just to tackle these takeoffs, and we'll discuss them in more detail. So firstly, we have to select what kind of LV lead we want to implant. So there are different curves and straight LV leads available. Curves can be a canted curves, which are double angulations on the lead, or a S-shaped bend on the lead. And there are bipolar and quadripolar leads. Quadripolar leads are far better than the bipolar leads in terms that they give you a lot of pacing options, especially in cases where you have non-response or phrenic nerve stimulation. So quadripolar leads are superior and should be chosen wherever possible. The only condition where bipolar lead may be preferred over a quadripolar lead is when you are implanting in a very small vein, and it would be difficult to push a quadripolar lead because the profile of the quadripolar lead may be slightly larger than the profile of the bipolar lead. The difference between the two is not very gross. But if the length of the vein is very small and you think that it would be impossible to fix all the 4 poles inside the vein and the proximal poles will remain in the CS, there is no point putting a quadripolar lead. You can go ahead with the bipolar lead. Select the delivery system. So there were multiple leads which were available that you can have a stillet driven lead or an over the wire lead. The over the wire lead is the most commonly lead we use in today's date. So these go over a O14 coronary guide wire. We just have to place a coronary guide wire inside the target branch and then put a lead over the wire. Position the guide wire as distal as possible in the branch. This gives a lot of support. It is even better if you can pass the guide wire through the distal branch through some tributary in another branch and then go to the CS into the RA. This gives a pura railroad system where on which you can get a good support and position the lead and push the lead into the distal branch. If more support is needed, you can use a more stiff guide wire with an extra support coronary wire, and if you can use an advanced sheath or a buddy wire for giving more support as we use in a coronary. So we can implant a over the wire lead. So this is an example where there is some tortuosity. So what is happening here, we have put a guide wire into the vein. So this vein has an angulated takeoff from the CS, and now we are trying to implant the lead which is not getting pushed easily into the vein because of the angulation. When we try to push the lead, it straightens the wire and it does not allow the lead to enter the venous branch. So what is the solution? So we can use a sub-selector here, or we can just put the CS catheter, push the CS catheter inside the os of that branch vein. So we can do that, but that may be sometimes dangerous, but it can cause a dissection at the ostium of the branch vein as seen in this case. So we have to be wary of this complication. So we can use a sub-selector here, which is an angulated catheter which can go inside the CS sheath, and inside that catheter we can then push the CS lead easily inside the target vein. This is a very helpful technique and we should always know about this. And there are many delivery guides, many shapes of the delivery guides available. So if the delivery guide is also not able to get inside the vein, then we can even use another vein selector inside that delivery guide. So that vein selector are also available with different shapes and curves which can help tackle the tortuous and angulated origins of the branches from the CS. So this is one of the inner catheters, shapes of the inner catheters we have available from the Abbott company. So this is CPS AIM catheters. So they are available in 3 shapes, which is an acute bend, a 90-degree bend and an obtuse bend. So according to what is the shape of your anatomy, you can choose one catheter and then go inside and then have more support to implant a LV lead. And these are the quadripolar LV leads. So that's what I was talking. The one on the left side is the canted leads, which has a double bend. These are called canted leads. So these are specially good for large veins which are dilated or have big diameters, and S-shaped leads are better for veins which are smaller diameters. So once you have implanted the lead, you have to take electrical measurements so that you know that the performance of the lead is good. You have to measure the LV threshold, you have to check for phrenic nerve stimulation, and if one of the LV threshold is not good, you can check for different polarities to see if you have a good LV threshold somewhere. So for checking the parameters, you should have a sensed R wave of more than 5 millivolts. You should have a voltage threshold of less than 3 volts. Anything below 3 volts is acceptable. Sometimes you might be miffed because you have been implanting a lot of RV leads that the threshold is 2.5 at 0.4 or 0.5 millisecond pulse width, which might be acceptable for a CS lead. And impedance is usually between 250 ohms to 1000 ohms. And you should always check at the 10 volt pacing for phrenic nerve, especially with a LV lead placement. And once you are done with this, you should always also check your RV and the RA lead while implanting the CRT. So one of the good ways that you will get a good response is to have a 12 lead ECG connected. Then you can see the intrinsic rhythm, see what's happening on the LV stimulation, see what's happening on the RV stimulation, and see if the ECG, the QRS is narrowing down on the biventricular stimulation on the ECG. So it is always helpful to have a 12 lead ECG or at least 6 lead ECG wherever possible. It helps you to determine whether there is narrowing of the QRS and see the actual clinical response of the CRT LV lead you have done. So this is an example where you have a CRT ECG and bi-V pacing is happening. You have a good narrower QRS and there is predominant R wave in V1 and a negative wave in negative QRS in 1 AVL, which says that there is a good LV pacing happening. Always look for phrenic nerve stimulation. I am saying this again and again because phrenic nerve stimulation is very, very painful for the patient. Painful in terms that it's very irritating and it's almost intolerable. You might actually need to switch off the LV lead pacing if the patient is having consistent diaphragmatic pacing. So it is most likely to occur on the LV lateral valve and it is expected to increase post procedure. So when you are doing the procedure, patient is lying down just still, so he is not moving much. So when the patient starts moving, gets up, he is in the sitting position or the standing position, the diaphragmatic pacing may actually improve and your lead might also actually move proximally or distally for 0.5 to 1 centimeter. So you should be wary of this complication that it might occur even if it is not there in the lab. So always carefully check with the 10 volt pacing. The solutions are, if it is happening, that try to move the lead proximally or distally and see if it is still happening. Try a different branch or change the LV pacing vector. Especially if you have a quadripolar lead and you are having a lot of diaphragmatic pacing in poles 1 and 2, then try to pace at the LV 3 and 4. If you are having a good pacing threshold at LV 3 and 4 and you are getting a good pacing without any diaphragmatic capture, you should be happy about it. And try to maintain a 3:1. This is a basic rule of thumb. Try to maintain a 3:1 pacing threshold difference between diaphragm and LV. So even if it is diaphragmatic happening at 10 volts or 8 volts and your LV threshold is 1.5, you should be fine because you have a big gap between the two and you can program the output somewhere in between. So once you have an adequate lead position, you have to remove the delivery system tools. So there are 2 methods. So this is the slit method which is shown above. So we get a special slitter which we have to fix the lead inside the slitter and then slit away the sheath, and then the next one is the peel away catheter. Peel away sheaths are available with Abbott. They are very similar to what you do with peel away sheaths in the RV and the RA lead implant. So one of the problems while doing this, removing the delivery system tools, is that while you start doing this slitting and splitting of the sheaths, you often, because the lead is not fixed to the CS vein, so you often end up dislodging the vein. So you have to be very careful that the CS lead dislodgement does not occur at this step. And to prevent CS lead dislodgement, so what you can do is first, step by step, remove the delivery guide first. So if you have used delivery guides or vein selectors, first remove them before moving the CS sheaths, so that the lead is stabilized inside the vein with the CS sheath inside, and then only try to remove the CS sheath.
You can also use a stillet at the tip of the lead so that the lead is stabilized and does not move inside the CS. And then once you are done with that, try to stabilize the lead. Then pull off, before starting to peel off or slit off, just try to pull off the sheet slowly into the RA, into the proximal part of the RA just below the SVC junction. And once you are there and the lead position is stable, you can start slitting or splitting at that point of time. So this is an example of leads splitting. So this is a peel away sheath. We are peeling the sheath. This is very similar to what we do in an RA sheath or a RB sheath. And coming to the last part of my talk is about the technical difficulties and solutions which can be offered. So common technical difficulties are the stenosis and the spasm of the coronary sinus or their branches. So we can pass a guide wire through this stenosis or a spasm and perform a low pressure balloon dilatation. This often helps to relieve the spasm or the stenosis, and then we can go ahead implanting the CS lead. There can be valves inside the coronary sinus, which we have already discussed. You can use a stiffer guide wire or a deflectable catheter so that you get more support to implant the CS sheath. And when we are talking about the lateral vein branches, we can use a subselector to get more support. If there is excessive tortuosity, we can use a soft guide wire to pass into, to negotiate through that tortuosity. And once you are through that tortuosity, then you can, for support, use a vein selector to pass through that tortuosity. Another common method is you can just prolapse the wire into the RA through a branch and then snare that RA branch through another venous access from the femoral end. Once you have done that, you will get a very good support and you can push anything and everything over that wire into the CS veins. If you have a very, if your lead is very unstable and it's coming out again and again, try to find a smaller branch or a second order branch. So if you have a main branch vein which is big and there are small branches arising from that big vein, you can wedge the lead into those small second order branches, and this allows the lead to be fixed and more stable. Or you can make U or L shaped lead tip designs by implanting into the second or the third order branches. If there are absent lateral veins, we have already discussed that you should try to look at the septal veins, the posterior and the anterior interventricular vein, and try to find if there are lateral branches. If there are none, then you are doomed. You will have to send the patient for an epicardial LV lead implant. If there is extensive scarring, then try to use a quadripolar lead and maximize tissue contact by placing into small branches, and place leads anterior or posterior to scar. Try to have a look at the echocardiogram, try to localize where your scar is. You can also have an LV angiogram to see what is the akinetic area in the RO and the LO views. You can, if the veins are very large, if the veins are variceal, you can use an active fixation lead, which is now available in Medtronic. It is a very good method because sometimes in very large veins, the lead will just keep on coming out. So you can use an active fixation lead to just fix the lead. It has a small helix on the proximal shaft and between the third and the fourth poles, and this helix gets hooked onto the tributary wall, and this allows the active fixation of the lead inside the CS tributary. However, if infection happens and this lead needs to be explanted, then it would be a big cause of worry. So should not be used routinely, but in difficult cases where large branches the lead is coming out again and again, you can always use an active fixation lead. Phrenic nerve stimulation, again we can change the configuration options and see. It is very commonly solved with the quadripolar leads. It was a big problem with the bipolar leads. We can always use an active fixation lead to fix the lead in a proximal location where phrenic nerve is not happening. Thank you.